All right, class, here we are back for trial run 2 with the video lectures. This time we're going to talk a little bit more about cardiac function. And to start, we're going to review some of the volumes we talked about on Monday. So first off, end diastolic volume, or EDV, is, remember, the volume in the ventricle at the end of diastole. So this is all of the blood that is in the ventricle when it starts contracting or during that isovolumetric contraction. Because all the valves are closed, there's going to be no change in volume, so it'll be the largest volume of blood we see in the ventricles, and that's going to be about 135 milliliters. And systolic volume is then going to be the smallest volume in the ventricle, and that's going to be at the end of systole. So once contraction has ceased, this is the leftover volume. So the ventricle can't pump out all of the blood during contraction, and this is going to be the volume left over during that isovolumetric relaxation, and it'll work out to be about 65 milliliters. Now, if you subtract ESV from EDV, you end up with stroke volume. So that's the amount of blood that's leaving the heart each cardiac cycle. We expect that to be about 70 milliliters. And that'll be the volumes we're primarily dealing with. We've also got a couple rates that are important. So first off, we've got heart rate. So we expect that to be about 70 beats per minute. And that's going to be simply the number of cardiac cycles we see each minute. And then we also have cardiac output. So this is just blood flow. This is going to be about 5 liters a minute of blood that is exiting the ventricles and going into circulation. We can calculate that specifically by taking heart rate and multiplying it by stroke volume. And again, this is really what we're interested in terms of cardiac function. Blood flow needs to be maintained so we get oxygen, so we get nutrients to all the cells. So that 5 liters a minute at rest is something that has to be maintained. Now, as we talk about stroke volume, the key here is that stroke volume is going to be a function of the force of contraction. So, as a rule, the stronger the contraction of the cardiac muscle, the greater the stroke volume will be. So the reasonable question is now, what's going to affect that force of contraction? Well, one, we mentioned Monday, the length of the muscle fiber is going to have an effect there. And that's going to be a function of end diastolic volume. How much blood is in the ventricle at the beginning of systole? Second is the contractility of the heart. Contractility is something we'll be talking about a bit more in a few minutes here, but that's basically boils down to the strength of a contraction. So as the myocardium in the ventricle stretches, stroke volume increases. The more blood you put in there, the stronger the contraction will be. And the term for this is preload. Preload, so the degree of myocardial stretch before contraction. Preload is the end diastolic volume. How much blood have we unloaded into the ventricle before it starts contracting? And that's what we're looking at this graph here. Now you'll recall we briefly looked at this graph on Monday. It's basically saying that at short sarcomere lengths, cardiac muscle is going to be weaker and it's going to increase its strength as sarcomere length increases. So the key with stroke volume, or one of the keys with stroke volume, is the Frank-Starling law. Frank Starling was not one guy. Frank Starling was actually two guys, which could be a source of confusion. But basically, the Frank-Starling law is going to say that stroke volume increases as end diastolic volume increases. So again, as I've just mentioned, the more blood in the ventricle, the more that's going to be pushed out. Now, end diastolic volume is determined by venous return. So basically, how much blood is coming back to the heart, that's going to determine how much blood is loaded into the ventricles, and that's going to directly influence stroke volume. Now, venous return is going to be affected by the skeletal muscle pump, the respiratory pump, and the sympathetic innervation of the veins. And those we're going to hold off a bit. So chapter 15, we're going to specifically talk about the blood vessels. So we'll hold off there, but recall that venous return is going to be affected by several functions of the vasculature, which we'll get to starting Friday. So here's the Starling curve. That's just showing you that here, as stretch of the myocardium increases, force increases. And what this is saying here is specifically is that as end diastolic volume increases, stroke volume is going to increase. Now here, we talked about how this curve relates to the skeletal muscle force length relationship. And basically, it's the same curve. We're just focused in on this very specific area here. So in terms of myocardium, we don't consider this increased length portion of cardiac muscle because it's not relevant. We're just looking at this left side of the graph. And in terms of cardiac muscle, end diastolic volume is going to be equivalent to the length in skeletal muscle. So the more volume we put into the ventricle, the more it will stretch. It will lengthen the sarcomeres, much like that linear length changes in skeletal muscle. Now, contractility is the intrinsic ability of the cardiac muscle to contract. It's going to be based on calcium availability, and it also is representative of the strength of contraction. And the key here is that contractility can vary. There are a number of things, including chemicals, that can affect contractility, and any chemical that changes contractility is considered an inotropic agent. So things like epinephrine, norepinephrine, and digitalis all have positive inotropic effects, meaning they increase contractility, increase the strength of cardiac muscle contraction. The opposite chemicals, anything with a negative inotropic effect, is going to then decrease the strength of contraction. And we can look at this graphically. What we have here is, again, the Starling curve. The control is the same we saw 2 slides ago. That's just showing us that as EDV increases, stroke volume also increases. As we stretch the myocardium, it's going to contract more forcefully and eject more blood. Now, the red line for norepinephrine is showing that under the same conditions, the addition of norepinephrine will further increase the contractility. It will further increase the stroke volume. Basically, the strength of the contraction is increased due to the norepinephrine. Now here you can see how epinephrine and norepinephrine actually affects cardiac muscle. So there's the beta-1 receptors on the myocardium. Epinephrine and norepinephrine are going to bind to those. They're going to activate cyclic AMP second messenger system. And we're going to actually jump to the bottom here to point out that epinephrine and norepinephrine will, 1, cause a more forceful contraction, so they'll increase stroke volume. They'll also decrease the time of contraction, so they'll shorten the duration of the contraction, which can allow for a greater heart rate. How do we get there? Well, on one hand, we have a phosphorylation of the voltage-gated calcium channels. They're going to be open longer. It's going to allow for more calcium to come in from the extracellular fluid. That's going to increase calcium release into this sarcoplasm and cause a more forceful contraction. On the other side of this, cyclic AMP phosphorylates phospholambda. That's going to increase the calcium HPHY in the sarcoplasmic reticulum. It's going to store more calcium, which allows for more calcium release, allows for more forceful contraction. It's also going to help remove calcium from the sarcoplasm faster, which shortens the binding time with troponin. Shorter duration of contraction allows for an increase in heart rate. So those sympathetic signals, epinephrine and norepinephrine, are going to help both increase contractility, create more forceful contractions, and also increase heart rate. So in this effect, we can increase cardiac output by both factors, both stroke volume and heart rate increase, so the blood flow as a whole will increase. Now looking at a flow chart regarding cardiac output, we can see that on the left, heart rate is going to be one of the determining factors of cardiac output, and that's heart rate itself is going to be determined by the rate of depolarization in those pacemaker cells. So here we can see decreases in heart rate are simply due to parasympathetic innervation. So we have parasympathetic signaling, it's going to decrease the heart rate, it's going to slow down that depolarization rate. That's simple enough. On the other side, increases in heart rate are going to be due to sympathetic signaling. So epinephrine is going to speed up the rate of the pacemaker cells. Now, as we go on the right side to stroke volume, it's a little more involved here. So stroke volume is basically a result of the force of contraction in the myocardium, and that's going to be influenced by two factors, one being contractility, the other being end diastolic volume. So end diastolic volume is going to be influenced by venous return. So the more blood that's returned to the heart, the more ends up in the ventricle, the stronger that contraction is, and the higher the stroke volume. Contractility itself is going to be increased also by sympathetic innervation. So the sympathetic nervous system has a few things going on here. Sympathetic innervation is also going to increase venous constriction, which is going to lead to an increase in venous return. Venous return is also a function of the skeletal muscle pump and the respiratory muscle pump. So as you can see here, there are a lot of factors going into stroke volume. We have a few more factors going into heart rate, and both heart rate and stroke volume together are going to determine our cardiac output. All right, so our vocabulary lesson is going to continue with afterload and ejection fraction. So afterload we haven't talked about yet. Afterload is the combined load of end diastolic volume and arterial resistance during ventricular contraction. Now, a couple things to think about. This is a different concept than preload, and it's really easy to think they're similar, to think they're opposites, and it's not really true, and I think that causes a bit of confusion among students. So just know that afterload affects cardiac function, but it's a different principle than preload. Basically, afterload is resistance against that ejection of blood from the heart. So these are the forces the heart must overcome to get blood out of the ventricles and into the arteries. And this is going to be a factor as we talk about ejection fraction, because ejection fraction is in one part determined by stroke volume, so how strong the heart is contracting. The other factor is going to be how much resistance there is to blood flow in the vessels. And as we mentioned, ejection fraction is stroke volume divided by the end diastolic volume. So how much leaves the heart compared to how much was in the heart at the start of contraction. And we'd expect under normal circumstances for that to be about 52%. So anywhere from 50 to 55 is a pretty reasonable number. All right, so now we're really going to get into it here with how the heart's working. What you see here is a simple little graph showing how the left ventricle changes in terms of pressure and volume during a cardiac cycle. As you can see on the bottom, on the x-axis, is left ventricular volume in milliliters, and then on the y-axis is left ventricular pressure in millimeters of mercury. And we're going to walk through this in a step-by-step process, and we'll talk about it again in class on Wednesday. But one thing to keep in mind, it's kind of overwhelming to look at to start, but if you can break it down, if you can piece it all together, you'll really have a very good understanding of how the heart works. That said, from the other aspect of it, if you can recreate this graph, from that you should be able to figure out how the heart works in terms of pressure and volume across the cardiac cycle. Now we're going to start off here with just the lower portion of the graph. So we start at the letter A, we're going to go to A prime, and this is just passive filling of the left ventricle. So here, blood is returning to the atria. It's basically just falling freely through the AV valves, just purely due to gravity. At A prime, we're going to see atrial contraction. So from A prime to B, the atria contract. They're going to push the last bit of blood into the ventricles before those AV valves close. So from B to C, it's isovolumetric contraction. All of the valves are closed. The AV valve closes once contraction starts because the pressure is higher than in the atria. We want to prevent backflow. But the pressure is too low to open the semilunar valves. So we can't get blood into the aorta yet until we build some more pressure. So here we have end diastolic volume from letter B up until letter C. Now at letter C here, we've reached 80 millimeters of mercury of pressure. And at that point, we're at the ejection phase of systole. So here, from this point, in terms of this decrease in volume, that's going to be equivalent to the stroke volume of the cardiac cycle. So here, going from 135 milliliters at end diastolic volume, we're going to go to 65 milliliters at end systolic volume. Now, once we reach point D, this is where the semilunar valves close again. The pressure is dropping below arterial, the semilunar valves close, and we get into, from D to A, is isovolumetric relaxation. So here, all the valves are closed. The pressure is lower than in the arteries, so the semilunar valves are closed, but it's much higher still than in the atria, so the AV valves are also closed. Now, through this period of relaxation, once the pressure drops, we'll start again over at A, where the AV valves will open and the ventricle will refill with blood for the next cardiac cycle. In one hand, it's a pretty simple graph. On the other, it's kind of unwieldy to learn the first time. So it pays off to kind of spend some time with it, really think about what's going on, because if you get it, you can really understand the cardiac cycle. And a couple things we'll talk about in class on Wednesday. I won't give you the answers here, but you can think about them. From this graph, you should be able to figure out what is end diastolic volume, what is end systolic volume, what's arterial blood pressure. If I give you a heart rate, what's cardiac output for that heart rate? And then what's the pressure in the atria? So these are a number of the things you can figure out based on this graph. Might not be obvious at first, but hopefully we'll be able to talk through it. You'll be able to look at it and really get a good idea of what's going on. So our last slide for the lecture here, it's also going to be a bit of a doozy, so good time to take a break, take a little breather if you want, or you just power through here. But another important one here is we're going to talk about what's referred to as the Wigger's diagram. It's named after the physician who, invented it, was the first to draw it out. And what you can see, it's really involved. We have a bunch of stuff going on here. Basically, though, much like a pressure volume loop, if you can understand this, if you could recreate this graph, you should have no problem answering any questions about how the heart works. So the bad news is it's pretty intimidating to look at, especially your first time. The good news is if you can figure out what the heck is going on here, you'll be in a great shape for the test and for just knowing how the heart works. So just to really simplify things, we're going to keep them just simplifying to these small portions of the graph. At the top here, we have the ECG reading. So here you can see the electrical activity that's going on in the heart. So we should be familiar with that. Hopefully you all understand how that works. If not, we'll talk about it. From there, let's go actually all the way to the bottom here. So we have the diagrams of the contractile cycle, the mechanical contractions of the heart. So you can see that atrial systole here is going to correspond with the P wave. Ventricular contraction is going to correspond with the QRS complex. So you can see how this starts to fit together. Now what we have here is this is on a time scale. So we're going from 0 to 800 milliseconds. And over the course of that, this pressure graph is showing how pressure changes in the blue, in the left atria. In the red is the left ventricle. And then in the black is in the aorta, so in the artery. Now what we see here, as the heart contracts, how do the pressure changes? How do the pressures change in these areas? Well, you can see that for most of the period, left atrial pressure follows left ventricular pressure. And for the remainder, the aorta then is going to mirror the left ventricle. So you can see we have a relationship of how blood is flowing, how pressure is generated, and hopefully you can figure out where are valves opening, where are valves closed, what's going on in each of the chambers of the heart. I'm certain we'll talk much more about this on Wednesday, but this is just going to be an introductory view of the Wigger's diagram here. Here, the simple line is just the heart sounds. We're really not going to worry much about this, but it shows you where you would notice those two main heart sounds in the contractile cycle, in the ECG cycle. But we're going to spend more time then looking at this volume graph here. This is a graph simply looking at the volume of blood in the left ventricle throughout the cardiac cycle. So you can see how it increases through ventricular diastole and then decreases through systole and then returns to an increasing state through diastole again. So again, I think a big part of understanding this graph is being able to break it down. It's hard to look at the whole thing and figure out what it means, but I think if you break it down into its component pieces, it's easier to get an understanding for what each piece means, how it relates to the next, and eventually you can put it all together. So I just put together, again, a few questions you can think about here. Again, what is end diastolic volume? What about ESV? What's arterial blood pressure? In this case, you can figure out what the heart rate is. If you know heart rate, what is the cardiac output? What's the pressure in the atria? And which segment here represents isovolumetric relaxation? Now, there are a number of other questions you can come up with, but those are some good starters. And again, the key here is that while the diagram is really involved, can be pretty intimidating and complex, if you can figure out what it means, if you can learn it, if you could reproduce it, you should be able to answer pretty much any question about the cardiac cycle and how the heart works. So I'll leave you with that. We'll talk more about this Wednesday. Until then, enjoy.